talked yesterday. I was like,
I know.
Oh, Lord, ladies.
y'all are.
Just a reminder, please mute your microphones.
Camera off there.
You want me to leave mine on, Christina?
Yes, please, since you're.
You're not on mute, Christina.
At 2:01, so we're going to get started. Good afternoon. Thanks for joining us for the Georgia Perinatal Quality Collaborative, our cardiac webinar series. Today's
Yeah, there's a
topic
2 o'clock where Bridget is
EHR
presenting, so I just want to be sure I jumped
of
on.
the maternal cardiac conditions risk assessment, hospital approaches to support buy-in for builds. Today is February the 6th, and we're just going to run through some housekeeping. Again, reminder, please, if you don't mind, to mute your microphones if you're not speaking. So this is just our mission and vision for the Georgia Perinatal Quality Collaborative. Just a reminder for you, the Georgia Perinatal Quality Collaborative was launched in 2012 with a mission for better perinatal outcomes and health equity for every Georgia mother and baby. This was in response to the fact that for years, being born in Georgia has been an at-risk factor for overall health, with Georgia ranked at the bottom nationally for maternal mortality and for many infant health indicators. Our mission is to engage stakeholders in implementing equitable, evidence-based perinatal care through a robust, data-driven quality improvement collaborative. All Georgia PQC initiatives focus on addressing the social drivers of health and improving health equity in maternal and neonatal care. Just a few updates for us. That our next webinar is scheduled for March the 5th at 2 p.m. So please feel free to join and place that on your calendar. Reminder that our quarter 2023 and cardiac data submission was due January the 31st, but we did extend that through February the 8th. And then it shows the subsequent other data submission dates and due dates. We did send out an implementation survey back in December. You can see the link here. If for some reason you did not get that or did not have a chance to fill that out, we'll still accept that. So please use that link to complete the SurveyMonkey implementation survey. And then just wanted to share an AIM February TAP webinar that'll be coming up next week, the 15th. Team birth strategies to improve your communication, teamwork, and shared decision-making for patient-centered care. This is, we're excited to be promoting and announce the Georgia PQC annual meeting is scheduled for April the 25th and 26th. That will be at the Emory Conference Center in Atlanta, and we will be sending out registration links in the very near future. So please make plans to attend that. And we've got a theme this year kind of going up the next generation.
Amy, if you're talking, I think we may have lost you.
Amy, it's Laura. If you're going through the slides, we can't hear you.
Can you hear me now?
Very faint.
How about now?
Nope.
Sounding better.
Any luck now?
I can't hear you, but maybe try to talk just a little bit louder into the
Okay.
microphone you're using.
Okay, sorry about that.
That's
So
good.
do I need to back up and go back through the slides?
Yeah, why don't you take one step back?
Okay.
Thanks.
Sorry for the tech issues. Gotta love Teams, guys. So we just wanted to share, this is our logo for our annual conference. It is scheduled for April the 25th and 26th. It's at the Emory Conference Center in Atlanta. So we will be sending out a registration link in the very near future. Please be on the lookout for that. February is Heart Month, so we just wanted to share some resources the CDC has published related to Public Health Professionals Toolkit for American Heart Month, and the link to those resources are available here. A reminder that this webinar and all of the resources will be posted on our website, so you can grab those at future time. We recently also had a presentation done for one of our women's health meetings, Talking Postpartum Depression by Danielle Augustine. And this is an awesome resource for using for women who are experiencing postpartum depression. So I have included Danielle's contact information here if you're more interested in having her speak at one of your upcoming meetings, and maybe reach out to her for those resources. And just a reminder that this is our website, so you can access all of our information, all of our webinars, all of our educational tools here. Wanted to share one more time the key driver diagram for the maternal cardiac conditions. And then these are our process measures for that work. The process measures are linked to the reporting and system learning key driver. They are evidence-based best practices and are considered key to improving healthcare delivery and outcomes. So just wanted to share that with you guys. And then this is the link to our educational resources that we created. These can be downloaded and you can use those in your facilities. If you do not have a way to download or print those in your facility, there is an email address there for Steve at Standard Press. All you have to do is reach out to Steve. He will print those materials and ship those directly to your facilities. And now I would like to introduce Dr. Connie Graves. Dr. Graves is an honor graduate from Baylor University. She received her medical degree from the University of Arkansas for Medical Sciences and was recipient of the Purdue Frederick Award for Excellence in Women's Healthcare. She completed her internship and residency at Vanderbilt University Medical Center. She completed her maternal fetal fellowship at Vanderbilt University. During her fellowship, Dr. Graves received special training in obstetrical critical care and became the director of one of the first critical care obstetrical units in the nation. She is previously a former division director of maternal fetal medicine at Vanderbilt University, as well as assistant dean for diversity. She is currently the medical director of Tennessee Maternal Fetal Medicine and the medical director for perinatal services at St. Thomas Health Systems. She is a professor at the University of Tennessee and serves as clinical and adjunct professor for Vanderbilt University and Meharry Medical College, respectively. She's a renowned speaker. We're happy to have her on today. She has many accolades. She's been instrumental in the formation of the Maternal Mortality Review Committee for the state of Tennessee, and she currently serves as a member of the Review Committee and a member of the CDC Committee on Bias in Maternal Mortality. In 2006, Dr. Graves, along with Dr. Stacy Davis, a cardiologist, started the Collaborative Perinatal Cardiac Center, a joint venture between Tennessee Maternal Fetal Medicine and St. Thomas Health, which is one of the first in the nation to address maternal heart care from the preconception period through postpartum care with a focus on long-term prevention. In her spare time, Dr. Graves serves as a keyboardist and choir director for her church and works with the youth ministry. So I'm very pleased to introduce today Dr. Connie Graves. Dr. Graves, I'm going to turn it over to you.
All right. Well, good afternoon, everybody. I'm really pleased to be here. As she said, I have special training in critical care, and I was telling someone that we didn't call it cardio obstetrics at the time. We just took care of a lot of women with heart disease. And back in when we did more invasive monitoring, and so I have extensive experience in taking care of these patients, and I've always had an interest in all things critical in maternal health and to prevent and how to prevent maternal mortality. So today they asked us for a catchy title, and I'm going to talk a little bit about our experience at St. Thomas Midtown. And so for my title, I chose Not for the Faint of Heart. Next slide. I have nothing to disclose. And what I'm really going to talk about is the importance of cardiovascular screening, how we implemented this in our EMR, and then develop some strategies to assist in moving forward in implementation at sites that provide obstetrical care. So I'm hoping to give some practical tips on how we did this and how to get your team moving forward. So I just want to remind us why screening is important. Cardiovascular disease, we know, is the leading cause of maternal mortality in the United States. And much of this is because often there's little suspicion for heart disease in this population. Most of them are young women, although I point out to my team that about a third of our patients at where I deliver are over 40, which again, if you were at that age, you get an EKG before you actually went to the to have your surgery. It's also responsible for maternal morbidity, including longer hospital stays, intensive care admissions, and future risk. And one of the reasons that cardiovascular screening became something that would caught everyone's attention is some of the work that Dr. Hamid has done, and I know she's lectured for you guys before, when they recognized that 92% of asymptomatic women would have had a screen positive and maybe would have received timely care that would have saved the mother's life. Next slide. So even though timely diagnosis of CVD is critical, the potential challenges really include pregnancy has many changes that can lead to signs and symptoms that are very familiar, or like shortness of breath, fatigue, or swelling. CVD is often not suspected in our obstetrical providers. And more importantly, many of our patients are not seen postpartum in the obstetrical area, so that it's not suspected in our ED providers. So it's not surprising that we have this issue. Next. We know that African American and Indigenous women exhibit a 3 to 4% higher rate of maternal mortality. And I don't know if anyone has been looking at the data recently, but some new data suggests that not only Indigenous, that is Native Americans, but Hawaiian Pacific Islanders also have this same fate. And so we are going to have to expand our racial and ethnic pool when we're looking at these patients. But in particular, because being African American is a proxy for people who may have been affected by the structural racism that has occurred in America, this screening tool has been shown to be helpful to reduce cardiovascular related morbidity and mortality. Next. So why is cardiac disease so difficult to recognize in pregnancy? And one of the things I like to do is, before I talk about the screening, next slide, is kind of the signs and symptoms. Today my patient came in and said, I've been more winded lately. That was my first patient. Well, she also has had COVID lately. So is that is that a problem? Is it not a problem? Fatigue, exertional dyspnea. I asked her, I said, have you had palpitations? But we know that's common. We also know that you can get a third heart sound in pregnancy. We're from the South, and when it's 100 degrees outside, everyone has pedal edema. And so it becomes difficult for us to figure out exactly who has what we should work up and what we should not. But on the right-hand side of this, if you're looking at the screen, you can see there are a number of things that we probably should work up. And probably one of the ones I like to highlight the most is patients shouldn't have chest pain, nor should they have sinus tachycardia that's 15% above their normal rate. These are things that that need to catch our attention. Next slide. So how do we differentiate? So this is from ACOG, and what they did is they gave a kind of a screening tool. But you can see this might be a little cumbersome and visually difficult. So reassurance, they have no history, they don't have any symptoms, they have normal vital signs, and they have a normal exam. Caution, they have no history, but they have some signs. Their vital signs may or may not be normal. They may have some things on exam that are questionable. And then of course, prompt evaluation are those things that I think many of us can recognize. They have a history of heart disease. They have self-reported symptoms. I remember once I was in the office and a patient came and she was getting her vitals and she laid across the desk. And I knew immediately she had pulmonary edema. And I think we can pick those patients up. So it's this middle section that I think our screening is looking at. So next slide. So how did we get started? We actually got started because Dr. Hamid from the called us, and she asked us to be a part of her the MORE grant because they needed a larger African American population that they did not have. So the proposal was to screen all pregnant women either during pregnancy or postpartum, and focused on two measures: those that had received screening and those who needed follow-up care. So that's kind of how we got started in our institution, trying to figure out what's the best way to get screening done, because the proposal was to screen all pregnant women. Next slide. And you can see this is the cardiovascular screening tool. And so what we did is I took this tool and I gave it, we reviewed it. And I said, how can we take this particular tool, put it into our EMR, make it easy for people to do, and make sure that everyone does it? And those are all often very complex questions to ask. And one of the things we found out doing this is that a lot of doctors and nurses didn't do physical exams. So something that we thought was so simple as the physical exam became an obstacle, especially in an outpatient setting. Next slide. So we did a Cerner build, and what we did is we engaged our stakeholders. Who do we need in order to have this happen? And in our particular institution, women access our obstetrical emergency room. So we felt that our obstetrical emergency room would be the first line of accessing these patients. So we decided that we were going to then screen all patients who were admitted to the hospital on labor and delivery, through the ED, or on our antepartum service, which when you do $7,000 to $8,000 a year, the deliveries of a year, that's a lot of screening. So the first thing we had to do is engage our stakeholders, which was nursing. Because I had a grant and a little bit of money, that made it a little bit easier. We had to engage our IT bill. We also had to decide if we were just going to build it for Ascension St. Thomas Midtown, which is the level 4, or if we were going to build it for Rutherford, which is our level 2 to 3, and for St. Thomas and River Park, which is our level 1. And so we decided that we were going to actually engage all centers. So once we did that and we educated the stakeholders, very much like we did at the beginning, about why we're doing this. Why is it that pregnant women and postpartum women need a special cardiovascular screening tool? We have one in our ED, and it screens all adults. And so that was part of the education, not just educating your nursing staff, but educating your providers and educating those people who may not often see pregnant women. Another place that I was very fortunate is I had a cardiologist who was already working with me, and Dr. Davis. So because when you start screening, how do we then take what we screen and how does it get worked up, and who works it up, and when does it get worked up? And then the next thing we did is we rolled this out to the nurses, educated them on where it was, and we made ours a hard stop. We developed a process for retrieving data that is still in place. I can go into our system and retrieve every screen. Because as I'm going to tell you some of the things that I've learned during this journey, that's really important. And then once we did all those things, we rolled this out for final implementation after we've done our testing. Next slide. So here's our build. You can see that it has the screening tool at the bottom. And what we basically did is took these assessments, and it will add up and tell the patient, say the patient screens positive, or she screens negative. Once that's done, the nursing staff is to convey to the provider, hey, your patient came in, she is here, she is in a triage right now, but I also want you to know that she screened positive on the vascular risk assessment tool. And depending on what that screen may be, is she short of breath? Is she hypertensive? Do we need to already treat her acute hypertension? Where we need to go with that depends on what happens. If the patient gets admitted, then she gets worked up of course, during that admission. But of course, patients may also screen positive because they're 40, African American, BMI greater than 35, and hypertensive, which is probably many of the patients that we see. And if you take out African American, then they're hypertensive and diabetic. And in the South, of course, substance use. And so here we are. What do we do with these patients? So we developed an answer for that as well. Next slide. So when the patient tested positive, but she wasn't going to get a workup in the office, we then gave the patient a card. And the card was like, you're special during your visit, we noticed that you need additional testing. And on the back, it says your patient to the provider has screened positive for heart disease. We suggest the following studies or referral to us, and we will work the patient up, we will work her up. And we told them this was part of the quality improvement project. And so this is how we got patients to come back into the system to be worked up for their cardiovascular screening when they were not admitted to the hospital. Next slide. And you can see that, so California Irvine, and I know that we're going to talk about Epic in a minute. We did our research. This is from Jack. We did our research. We are number 3, the hospital system number 3. And you can see that 98% of our patients had a risk assessment. But we were not as good as with follow-up because one of the things that they did with their risk assessment, which I wish we had done now, is they actually were able to build out into their particular quality, into their EMR. They were able to build out the labs and things of that nature. And I think this highlights for me the difference between working in a system like when you're at Emory, or when you're working with 100 providers who aren't beholden to the system. So that so in this particular instance, I think we tested 2 things. Yes, this can be done in a private hospital, and yes, you can create options for follow-up that don't step on the private doctor's toes, but still assist with quality improvement and getting that patient in for appropriate care. Next slide. So what did we do with the positive screen? The patient would get a CMP, and a BNP if she was having arrhythmias and she was getting admitted. She would get her thyroid functions and a CBC. I will tell you that a number of these patients who screened borderline were anemic, which I found to be fascinating. We also did EKGs and echoes and event monitoring if it was applicable, especially telemetry if the patient got admitted. And in our hospital, we currently screen for substance use. Everybody gets a urine screen, so we also screen patients in that way. One of the things I want to point out, I think what a positive sign for this is as we are very BNP and echo forward on the OB service. Next slide. So then we would send people for further evaluation. We would refer to cardiology for if the patient had abnormal initial testing. We would, again, like I said, event monitoring and the consideration of anemia. And someone else actually found this that suggested ECG changes in tachycardia were found in 90% of patients with anemia. Next slide. Well, they told you that it's going to take you as long to build this out in your EMR as it would for the patient to have a baby. What do I do? So I've also provided what we did in our office, because that's what ECW said. And we were able to track these in our office using a paper chart. So in smaller areas, this may be something that you prefer to do. It is easy. In our chart, you had specific instructions about what to do, where to do it, and where to return it to. Even what to do in your EMR. It says CVS tool completed date, and you put it on a sticky note, which in ECW is the yellow notes in the chart. So we had a system in our office to do screening even when it wasn't built in the EMR. And for those of you who want to get started, this may be an option. Next slide. Things that we have done well. The screening tool is a hard stop. The nursing staff must stop at it to get to do the screening. However, a hard stop doesn't mean that always people fill it out correctly. So that's an ongoing quality improvement process. Then we did a good job of educating providers, so workup is being performed prior to being referred to cardiology. One of the things I learned from my friend, the cardiologist, is, they don't want to see a woman with palpitations if they can avoid it. But so what we will do is we will see the patient in our maternal fetal medicine clinic. We will order their ZO. We will take or their Holter or event monitoring. We will take care of everything that needs to be done. And then if it's abnormal, we will refer to cardiology. We will get their echo and EKG. So they're not just being bombarded with a lot of women with positive screens, especially when you have limited resources. I will say that we've increased the awareness of cardiovascular disease in this population. It is rare that we do not perform echoes on our patients, especially with elevated BNPs. As many of you work in hospital systems, sometimes they can't retrieve their data. And I said, well, I can tell you today we ordered 8 echoes on the floor because we had a lot of preeclampsia, a lot of shortness of breath, and a lot of patients with hypertension who screen positive. And I think the other thing we did well is we developed these tools for all of our obstetrical hospitals, regardless of level. So now that we're doing this project in the state of Tennessee, our level 1 hospital is also able to participate, which is a great win for them. Next. What I wish have done, like I said, made the positive. One of the things I really wished is the positive fired in the chart as a notification, because you're relying on human communication, which means the positive screen cannot be conveyed. And we had a patient who would have screened positive, and no one, she wasn't done well, or they didn't screen her and she coded back in the back. Luckily, she was able to recover. But as we said, if we had known she screened a positive of 5, maybe care would have been different. So that's one of the things we wish we would have done better. One of the things I'm in the process is I'm in the building an order set that automatically triggers with a positive screen, especially for those patients who are staying inpatient. And then we're working on this now, but because we had an OBED, one of the things we did not do as well as we should have is develop this process for the emergency room. That's a hazard of being at a larger center. And I think that that's one of the things I wish we would have done better, is involving the ED, and we're in the process of going back and trying to move them in now. Next slide. I just want to remind everybody that continuous quality improvement means that you have to continuously quality improve. And so one of the things that we're on now that we are currently part of the TIP-QC project is going back and looking at the validity of our screening data and making sure that our staff is screening patients appropriately and identifying those patients that need a higher level of care. And as I said in the case discussion, I just want to emphasize the importance of cardiovascular screening. Again, that was the patient I was just talking about. there was no reason for that patient. She screened 5. There was no reason we should have been in the back, not knowing that, and then having an untoward outcome. So we know cardiovascular screening is helpful. It is what we all need to be doing. And how we do that, we all may arrive at it in different ways, but as long as we're doing it and able to quantitate that we're catching as many patients as possible, we can make giant improvements in this patient population. I thank you for your attention. I'm going to turn it over to Bridget, who's my colleague.
Thank you so very much, Dr. Graves. We really appreciate it. So I'm happy to introduce our second speaker for today. Bridget Schulman has over 20 years of experience in women and children's services. Bridget has a master's in nursing education and has completed her PhD in nursing. She is certified in inpatient obstetrics, external fetal monitoring, is an A1 fetal monitoring instructor, and obstetric patient safety instructor trainer. Bridget served as a bedside nurse in L&D for 10 years, the nurse educator for L&D, the clinical practice specialist of the Women and Children's Services, and currently serves as the clinical outreach specialist for Hope for Georgia Moms. This is a maternal and health and innovation grant to improve maternal health outcomes in Georgia. Bridget is passionate about patient safety, which led her to also obtain the Certified Professional in Patient Safety credential from IHI. She uses her knowledge and experience to continue to improve equity, quality, and safety of maternal and perinatal care for all birthing people across Georgia. So I'm very pleased to announce and introduce and welcome Bridget Schulman.
Thank you so much. And Dr. Graves, that was amazing. What a great foundation to follow, and really, really appreciate that. So as, next slide. As Amy mentioned, my current role, one more. I'm currently serving as the clinical outreach for a HRSA grant that we have named Hope for Georgia Moms. And the HOPE stands for Healthy Outcomes and Positive Experiences. And we believe the only way to get to that hope is making sure that all moms have equitable experiences. We know that it's going to be imperative to have access to care. And through all of this, we do not just want the standard to be that our moms survive, but they truly thrive and have joy and really have great lives after, during, and after their birth experiences. So just a second to kind of lay the landscape of what Hope for Georgia Moms is. It is a grant from HRSA, as I mentioned. We are part, there have been multiple cohorts of grants provided by HRSA, and we are one of 9 states to receive this grant in the second round. This grant was awarded from, it's a 5-year, $5 million grant. And the intention of the grant is to address gaps in direct clinical care, workforce training, maternal health, data enhancement, community engagement, and understanding that equity and innovation is integrated through all of the strategies that we come up with. Next slide. And just for perspective, as of October of 2023, there have been 3 cohorts now. So there are 35 states that have now been funded with similar grants. But in cohort 2, which we are part of, you can see the 9 states that received this grant. And I think it's unique to understand that the Northeast Georgia Health Systems Foundation actually received the funding, and then the HOPE team is responsible for implementing it throughout the state. So just kind of making those connections and just some transparency on some of the many states that have also been awarded this grant. So I know that we laid a great foundation on maternal mortality rates. This is a map of the entire United States. And you can see some states are doing well and some states are not doing so well. And I'm sure it is not a surprise to anyone on this call that Georgia continues to rank in the bottom of our maternal mortality. Next slide. And the most recent report that is from the maternal deaths of 2018 through 2020, you can see in the chart the leading causes of death include hemorrhage, mental health, some of the cardiac conditions, preeclampsia, embolism. But I think it's important to recognize when you combine cardiomyopathy and the coronary and cardiovascular disease, these cardiac diseases really are a major contributor to maternal death. And I think it is amazing that our state GAP QC chose to focus on this AIM bundle. We also recognize that 89% of all of the deaths in Georgia could have been prevented. And when we look at those individually, those can be up to 100% when you look at some of those more specifically, but overall. And we recognize that inadequate screening and follow-up care is one of the things contributing to that maternal death. Next slide. So if we know that this is a problem and we know that cardiovascular disease continues to contribute to the maternal mortality, how are we continuing to miss the mark? I think Dr. Graves also did a great job in just recognizing that some of those kind of normal abnormals of pregnancy are also some of the biggest things that we see when it truly is cardiovascular disease. So you can see here that sometimes it's that a delay in adequate response when there are clinical signs present. Ineffective or inappropriate treatment, a misdiagnosis, or just failure to refer to the proper specialty area. Next slide. So I know Amy opened us up with that great key driver diagram that we all are familiar with that are part of this bundle. And so at our organization, I tried to make one that was just a little more palatable, and so we can just sort of start taking this step by step and start kind of checking things off. So this is the kind of the key driver diagram that we're using at our health system. And you are all probably also familiar with the R's, the readiness, recognition, response, reporting, and we know that respectful care really should be embedded in all of the things that we do. So this is just sort of a visual that we're sharing at the OB sections and with the nursing staff and leaders, so we kind of understand what steps we're taking, what steps do we need to take to implement this AIM CCOC bundle, and then where are we at, what have we accomplished, and kind of what our next steps are. Next slide. And so I think as we start this, I will echo Dr. Graves' title that this quality improvement is not for the faint of heart, for sure. And particularly with this cardiac initiative, this is not an OBGYN project. This is not, you know, some of us have taken on the hypertension bundle and the postpartum hemorrhage bundle, and it was really something we could really manage in sort of the OB department and with our labor and delivery and mother baby. But this bundle is complicated and it really does take a village. And so I you know, really encourage you to think about who is it at your organization, whether you've already started this journey or whether you're just watching in the collaborative as a learner. Who is it that you think you need at your table to start this journey? And so for us, we knew that we needed our OBs, obviously. We need our maternal fetal medicine. We need our cardiology partners. We do also have an antepartum unit. So those are kind of the obvious, but also, you know, we've all highlighted that we know these moms are going to come back through our urgent cares and our emergency rooms. What about our paramedics that are going to be the ones that get the 911 calls sometimes? So how do we make sure that we include everybody that can touch our pregnant and up to 365 days postpartum team? Next slide. And so for us, this is just an example of the team that we started with. And I will share, we had applied for our grant, but we really started this journey because our perinatal quality collaborative chose to focus on this. So we came to the table without a grant, without any of this at Northeast Georgia, because we've been engaged with the GAP QC's initiatives for many years. And so we knew that this was the bundle that we were taking on this year. And so we came to the table and just realized that our cardiology team had a vision of starting a women's heart center at the same time that we were realizing that this is the focus that we're going to have. So we really were very blessed, I think, that we had a cardiology that was sort of in that same mindset. So we do have a physician champion with our heart center. They had planned to hire a mid-level, so an APP or a PA for the heart center as well, to really kind of help navigate and, if you will, triage in a way these women that get the risk factors. And so we all know there's so many different kinds of cardiology, and that's another thing that complicates this. So this role really was designed to sort of be that first touch, and I think we'll touch on that later on. We do also have a pharmacist, which we believe is playing a key role in many different aspects of our moms, whether that's blood pressure management, birth control, mental health, diabetes management, a lot of different angles, smoking cessation. So really a key piece of this team with our cardiology team. And then we were very purposeful to make sure that we had emergency room presence, and then of course our OB physician champion as well. Next slide. So now I'm just going to take some breakdowns of that key driver diagram. We're just going to focus on a few of the tasks, if you will, or some of the metrics. And at our organization, we focus very early on the screening tool because we really believe that recognition is the first step in anything. So if we don't recognize them, we're not going to refer them, we're not going to pay attention, we're not going to do further testing, we're not going to do any of that if we don't recognize that there is a risk for CDD. So that was really important to us in the beginning. And so you can see here, screening all women that are pregnant or up to 365 days is the recommendation. And so determining what that tool is going to be and getting that built into Epic to make it sort of easier to do. And so it was easy to find the tool that you're going to use, because the CMQCC has the validated tool, as Dr. Graves mentioned, and the work that Dr. Hamid and team have done. So that was the easy part. And then I have to say that I feel the pain of the Epic integration, which I'll talk a little bit more about if you want to go to the next slide. And maybe one more. Yeah. So it's really important. I think the key point is really, we need a tool. We need to screen these women. We know that that is a key element to recognize those that are going to be at risk. We need something to do with them. If they screen at risk, what is the standard process to make sure that we get them to the right place at the right time, and then get those referrals? Next slide. So as I said, we started our Epic integration, and the very same tool that Dr. Graves showed, that again is from that CMQCC toolkit on recognizing those different symptoms, vital signs, and risk factors. And then there was the physical exam piece, and then of course there are the red flags. So we took that very same algorithm, and we faced some series of unfortunate events, if you will. We were very fortunate to be able to onboard a new facility, Habersham, which is a facility that our network took on, but all of our IT resources had to go to integrating Epic into that health system. So when we felt like we were almost there and about ready to launch this in Epic, we had a complete standstill. So just as Dr. Graves mentioned, we took the opportunity to pivot and said, we're going to do a pilot of a paper risk assessment. So this is the version that we came up with. You can see again, we have the symptoms, the vital signs, the risk factors. We have our red flags and the physical assessment components. And I'm sure that many of us are familiar, but the logic on this is if there is at least one in each of the categories on the left, so at least one symptom, one vital sign, and one risk factor, that is a positive screen, if you will, or that triggers an at-risk result. Or if there's 4 in any of those 3 categories, so if there's 2 symptoms and 2 vital signs, or 3 symptoms and 1 risk factor, that also triggers an at-risk result. If there are 1 red flag or 1 physical positive finding in the physical exam, that is an automatic trigger as well. So just we were really clear on how to score this, because this had to be done manually on the paper, and then it had to be scored by the bedside nurses. So, and next slide. And I just want to talk, these were a lot of deciding points when we decided to do this pilot implementation of a paper version. The who, the when, the where, who's going to do this, how are we going to do it, when are we going to do it? And so I just wanted to kind of lay out how we chose to do it. And so what we decided, we didn't want to be doing, we're like, oh, should we do it 24 hours after delivery? But then if they deliver at 2 in the morning, nobody wants to be screening at 2. So we just decided across the board, we were going to do this on the morning assessment the day after the patient delivered on the mother baby unit. That's where we started. And then again, they completed the paper version. They added the scores up. They decided if it was at risk or not at risk. And then we did implement, and I'll talk about this on the next slide, but there was an order protocol, if you will, and I'll explain that in just a second. So after that, they took that paper risk assessment, they made a copy of it and put it on the chart so that when the cardiology team came, they could see what triggered the at-risk result. And then that same piece of paper did go down to medical records and was uploaded into the medical chart during that pilot time when we were a paper version. And next slide. And so again, it's really important if you're going to screen that you have a standard process. And so this was our standard process. We created this order panel, and this really was a partnership decision on what did cardiology want. So they were very familiar with the tool. We shared the tool that we were using. So what did they want to be done if a patient did screen at risk as a result of this screening tool? And they determined that what they wanted was a proBNP and an EKG. And our team also decided that for us, it was important that we had an inpatient consult. So that PA that we talked about that was hired just for this project that we were doing, really, we think it's important that before they leave, that cardiology has that personal touch with them to say, hey, we're from cardiology and you have screened at risk. And we provide some education, and then we make sure that we set an appointment with that patient. So that was just something really important to our team in the beginning. And so this order panel is a reflection of those decisions made and combined with the OBs and the cardiology team. And the other thing I'm just going to point out here, a deciding point was if the patient screened at risk, would the OB put in the order, so they would order the order panel. And our organization decided, our OB said it was important enough, if they're triggering on this screening, they wanted the things done. So if that's what cardiology wanted, so we actually made this a nursing protocol. And so if you're familiar with that, if the same thing's done every time, the OBs didn't have to be told every single time. These things were done if they screened, and then the OBs were notified and the cardiology was notified. So that was, again, just sort of a process deciding point at our organization. And so, again, you can see that there is a lab on there, there is a procedure, the EKG, and then that inpatient consult on our mother, baby, women, and children's pilot paper. Next slide. And so we went live in August, and then on 12/5, these results are from the pilot paper version from when we went live in August through the point we started doing it in Epic on 12/5. And so we total scored. We only did this at one of our locations for that pilot. So 444 were screened. We had 20 positives. And so that was about a 4.4% positivity rate. And just to note, there were 3 additional consults placed by the OBs, even though the patient had screened negative for different clinical reasons or presentations or maybe a history, that just the OBs wanted that consult placed. And then I think another really cool thing that happened is there were ambulatory referrals placed from many different places, including the office and even the emergency department. As we improved the awareness of the CVD risk assessment, what it was, that we were building it in Epic, there were referrals put in just because there was increased awareness and not because we checked boxes and said, yes, they were at risk or not at risk. So all of those things we learned from our pilot. And the other thing I want to share is in the graph, you can see the reasons that they were triggered. So remember, I said if there was one in those 3 categories, that is 3 in each category, and you see 4 of the referrals were that. 4 total, so it was 4 in any combination of the symptoms, vital signs, and risk factors. 7 were a result of that. 3 were direct red flags, and 6 were from physical assessments. Next slide. Now let's talk about how we integrated it into Epic. So I just provided some screenshots, and I'm happy to answer questions as we go, but I wanted to really show you where we put it, how it's accessed. So it is under patients chart. They go to the flow sheets, and then there is a CBD screen. Next slide. And then those 3 sections, you can see the subjective symptoms, vital signs, and risk factors were built in. Those are answered by the nurse on the mother, baby, or antepartum unit. That's the areas that we complete this. And they must hit file. They must answer all the questions, and they must hit file to receive a score. And so you can see at the bottom, they will either get a result of not at risk or at risk. So all of that logic, the 1, 1, and 1, 4 in any, 1 red flag, 1 physical, all of that logic was built behind the scenes. And so what the nurse sees is either it's at risk or it's not at risk. That was very important to us. And so you can see there at the bottom, the screening result was either at risk or not at risk. And then they enter the providers that was notified of the screen. Next slide. We used the same order panel, and the decision was made. So once we got into the Epic integration, we used the same order panel that we used with the paper pilot. We already talked about the 3 things that happened, and this also remained as a nursing protocol once the Epic integration happened. And next slide. And what I think is very helpful with the Epic integration is that we were also able to create BPA, so those best practice advisors, that when a patient screens at risk, when that result comes up at risk, this is what the nurses see, and it fires that your patient screened positive, and you can go directly to that order panel right there on the screen, and then they're able to just put that order panel in, and then they hit accept. Next slide. There is also an automatic BPA for the provider, and this is what that one looks like. So the next time that patient's chart is opened by a provider, they will get that BPA that lets them know that this patient did have a positive CBD screen. And we tried some different things with this. We think it's kind of a lot of information. We really would have liked only the positives to be present. It's maybe a little bit sensory overload, but we thought it was important that the providers were aware what triggered the positive result. So you can see that what triggered it is in red, and then they can acknowledge that BPA. And next slide. And so as we know, we are taking a phased approach. I like to say you can, and I know Dr. Kopke loves this, you can eat an elephant 1 bite at a time. Not any of us eat elephants, but we have to start somewhere. So our phase 1 was the inpatient mother, baby, and antepartum units. But we do have a phase 2, 3, and 4, which I will talk about in my final slide. But as we recognize that we are going to be moving from different platforms, so we have the Stork platform in Epic, and then we plan to go to the OB offices, which is your ambulatory, we knew that it was going to be important that there is awareness that this patient screened positive. So we were very intentional to make sure there was an FYI flag. So if you're familiar with the storyboard in Epic, it's in that top left corner. And this is the message that you'll see in the FYI flag: positive maternal screen. This can be removed in 365 days. And so a next step of education was that the mother baby nurse, before that patient is discharged, just needs to enter the delivery date. So there is awareness when the 365 days is up. So again, this was part of our education and rollout. And next slide. And so what's the who, when, and where for the Epic version? So similar to the paper version, for the Epic version, risk assessment, Epic, so they answered the questions. They have to hit file or will not give a result. The nurse and provider then are provided a BPA with steps to take. If the patient scores at risk, we use that same maternal high risk protocol, which ordered the BNP, the EKG, and the inpatient consult. And then the nurses responsible for making sure that the OB and the Women's Heart Center PA were notified of the risk. And then I talked about that last step of making sure they enter the delivery date. We did try to see if that could automatically fall off in 365 days, and it wasn't possible. So it is a manual process to get rid of that flag, but we know that it's going to be important the delivery date is in there. So just, again, some of the education we did as we went. Next slide. So this is the results as of a few days ago. I just pulled some of the statistics. So we've screened 635 in our main campus. Our bigger campus had 17 positives, so a 2.7% positivity rate. And then in our smaller campus, which is also where we did the paper pilot, since we went live on 12/5 in Epic, we've screened 254 patients, 8 positives for a 3.1% positivity rate. And I think it's really important. We are sharing weekly how many positivities with our nursing staff once we went live in December, and then we're going to go to monthly, but we also share this with OBs, with the cardiologists, because one of the biggest fears is, oh, I mean, look at what's on that screen. Everybody's going to score positive. Cardiology is not going to be able to handle this. There's no way. So we really have some numbers, and our pilot helped us with that as well, that it really is not a huge, as some people were afraid or kind of feared in the beginning. Next slide. And then again, pulling back out to the recognition piece of that key driver diagram. I think this was, it should have been an easy win, but it was maybe a little more difficult. But, you know, one of the things is that all of these different care environments that see pregnant and postpartum women are asking, not only are you pregnant, but have you been in the last year? And so one of the metrics that we report is, or the S2 metric is, does your ED ask the question, are they pregnant and have they, or have they been in the last year? And our AD asks, are they pregnant? But they weren't asking that second part of the question. And so on 12/12, we were able to make that Epic change. And so now they do ask, not only are you pregnant, but have you been in the last 365 days? And I think, again, this goes to something I think Dr. Grace did a great job of explaining, is that people don't always think about cardiovascular disease, especially during the postpartum period. So this really is, hey, I need to be paying attention for a year. And so if I'm answering yes to this and this patient's come in with shortness of breath or some of these things, I need to think possibly, you know, some of these pregnancy related or preeclampsia or some of these other things, cardiovascular disease. So we were able to add that to the ED triage navigator. And that will also be a question as we move into our future phases in urgent cares and other areas. Next slide. Okay, and so going back to another R, so our readiness, these again from our key driver diagram, we have to train all OB providers and nurses assigned symptoms of cardiac conditions. And then so how are we going to do this? We're going to develop and disseminate educations on these things. Next slide, please. And so one of the things, in order to prepare to go live in Epic, we had to do some education across the board for people to understand why we were doing this, how we were doing it, what the BPAs were going to look like. And so, if you will, we kind of created a homegrown education module. So we reviewed signs and symptoms of cardiac conditions. We gave the background on the CVD risk assessment and how it was determined, how it was validated, what the components of it were, and really gave that background in preparation for our go live, but also was able to meet the criteria for that. All OB providers and all OB nurses, we assign this in our organizational learning system, so I can then track it, who's completed it and who hasn't. And then there's also other ways to accomplish this metric. And I think we've talked a lot about this in a lot of the GAP-QC discussions. And one of the things that is being worked on is AWON has a whole series of CCOE modules, if you will, and one is specific to cardiac condition. And so they are, and they were previously bundled. And so they worked with our team to pull out just the cardiac modules and have it available for purchase. If that's how you want to go, and it'll have CME and CE credits. Doing a homegrown system. There's talk about Relias maybe having a cardiac. So there's a lot of different ways to meet that metric, but I just wanted to share that with the team as well. Next slide. And then our GAP QC has provided some great tools. And so maybe you aren't at a point that you can actually complete the entire risk assessment, or maybe, you know, our emergency room, you know, we sometimes have to meet people where they are. And so even just raising awareness, using tools like this to say, hey, these are the things we look for, and these are the things that are in that risk assessment. So even if you can't complete the whole thing, having these tools, providing them to maybe your emergency rooms, your offices, places where women are presenting, even maybe as a first step to increase awareness, and then as you operationalize how to get a screening tool in. Next slide. We love our peach card, so if our moms do screen positive, this is the education we provide to them when our cardiology PA meets them. They go over these materials, and we use these tools. Next slide. And then, to be honest, our cardiologies loved these tools, and our OBs love these tools. So, you know, OBs don't want to do cardiology, and you know, a lot of cardiologists, I'm not going to say all of them, but, you know, don't love the whole OB piece. And so these tools were really helpful to both teams. So use those. Those are also available online. Next slide. And I know the team worked really hard on these. One more slide. And so real quick, I'm going to just share a couple of lessons learned. I know we're at the end, and I'm so sorry, but one of the things with the physical exam, and again, Dr. Grace pointed out, not everyone was doing this. And so one, to ask them to do this, but two, to identify what is a loud murmur. I mean, you know, there is a physiologic murmur with all pregnant people. So we're talking about a loud one. So this was actually included. And then what is it about the crackles? You know, it is, some things are normal, maybe swelling, but it's not normal to have crackles in your lungs. So really, this was part of our learning modules. This was on huddle boards. This was in staff meetings. As we asked people to complete that physical assessment, really a loud murmur is, you know, what that is, and just sharing that information. Next slide. Also, I think it was important to differentiate a positive or an at-risk screen because you had 1, 1, and 1, or 4 in any, can be a little bit different than if you have a positive screen because of red flags. And so we really had to educate, you know, if you have these red flags, that's not just a, you know, put in that order panel and call it a day. That we need to call the OB, that we need direct attention on. So just, you know, that was something we learned during our pilot. And so we were able to be very clear in our big go live at all the campuses. And next slide. And then just our next steps. I've alluded to this numerous times, but we are launched in phase 1. So our phase 2 is we are going to complete assessments in our OB offices and primary care. And what that looks like is they're going to be screened in every trimester and at their postpartum visit. And then just when they present to primary care, which in 365 days might only be once. And then our phase 3 is our urgent cares, and our phase 4 is our emergency department. And then we're also working on remote patient monitoring and the operationalization of telehealth, and how that's really going to partner with the work that we've done. Next slide. Sorry, I went over about 2 minutes, but yeah, that's all I got.
Thank you. Thank you, thank you, thank you so much, Bridget. Thank you, Dr. Graves. Really appreciate it. Did want to add in, and Bridget, you and Dr. Graves will probably be an integral part of this, but we want to do a phase 2 part of this webinar where we actually get your IT folks involved in the webinar and start the actual build for the Cerner or Epic, which one is applicable to your facility and your hospital. So there's more to come on the backside of this webinar for digging in with the IT folks on beginning that build. But do know that we are a resource. If you have any questions that we don't have time to cover, please send that to me in an email. We'll get that out to Bridget or Dr. Graves and get those answers back to you. But thank you so much for joining us today, and we look forward to our next webinar in March. Thank you all for being a part of this GAP QC work, and thank you for all the work that you do out there on a daily basis. Have a great day.
Thank you.